It's a great pleasure for me, really, to present at this meeting. And I'm going to, I guess, give a presentation, I think, at least highlighting some of the uncertainty I feel as a cardiac anaesthesiologist in my practice. And I work at the Alfred Hospital in Melbourne, which is the largest trauma centre in Australia. And it is a common dilemma for us in many types of surgery of when and if we should be using it, when and if we shouldn't. And of course, that 3-hour time zone factor occasionally comes into play. That doesn't work, so I'll move to this one. Here we go. So I guess my interest in fibrinolysis is much more particularly tranexamic acid was as a cardiac anaesthesiologist. And we started planning this Atticus trial really at around 2004, 2005. It took a number of years to do some background work, and then we were successful in getting a big national grant to do this Atticus trial. And in this trial, I was very pleased to demonstrate in cardiac surgery that, in fact, you could clearly get a reduction in bleeding complications. But more importantly, the concern was at that time, particularly for coronary artery surgery for patients who are clearly atherosclerotic and at risk of myocardial infarction and or stroke after surgery, that it wouldn't in any way be prothrombotic. And what wasn't, I think, well articulated in this publication was, in fact, there was a reduction in myocardial infarction in those that got tranexamic acid. So perhaps the highest risk thrombotic type of surgery that we deal with, coronary artery surgery, in that setting, I think it was incredibly reassuring for us. And I think although as the years of the Atticus trial went by, the equipoise shifted and people were more and more using such agents, I think this trial really, put the lid on any concerns related to TXA in cardiac surgery, and more importantly to, increase its use as a very routine drug, including in off-pump surgery. So it was a great experience for me. It was very much an international multi-centre trial. We ran it across 31 hospitals in 7 countries. And in fact, it was the first trial, I think, as an individual trial rather than a pooled analysis or meta-analysis to clearly demonstrate a reduction in blood transfusion. At that time, I think we kind of knew that, but that was really from meta-analyses. And I do like large pragmatic trials. And the reduction in need for blood transfusion was, I think, pretty dramatic, really, across the board. And most importantly for me, who otherwise would have to get up at 2 o'clock in the morning to deal with a cardiac tamponade the first night after surgery, the fact that we could reduce reoperation for hemorrhage was a really important factor. So that was great. But of course, what about in other surgery, particularly non-cardiac surgery? The POISE-3 trial led by PJ Devereux, a very good friend of mine, working with colleagues, some of whom work with me in our other multi-centre trials, and some had been involved in our Atticus trial. And how should we interpret that trial in non-cardiac surgery more generally? And I must confess I've got a different view to PJ Devereux, a cardiologist, who seems to be fixated on the heart, and I'm fixated on bleeding and infection. So I'll just jump forward a little bit now to this article that came... Beverly, were you involved in this presentation? This came out from the UK Royal Colleges in 2022. It was following the POISE-3 trial and I guess other studies that were being done. It included Ian Roberts, who led the big crash trials. And they made this statement in the article. Now Mike Grocott is a very good friend of mine, like seriously good friend. And I just simply don't agree with this statement. I think 1.5 of these claims are correct. I'll get back to it in just a moment. So coming back to POISE-3, this was the conclusion in the New England Journal article, and this conclusion, among patients undergoing non-cardiac surgery, the incidence of serious bleeding was lower with tranexamic acid than placebo. I agree with that wholeheartedly, highly consistent with all the other evidence that we know about tranexamic acid, and it was, I think, a very true and believable effect. And importantly, although the between-group difference in the composite cardiovascular outcome, which was a co-primary outcome, was small, they could not establish non-inferiority. So my take on most of the evidence up until recent times is this. I think there's absolutely no doubt that TXA should be used routinely in effectively all cardiac surgery. The optimal dose, though, is still unclear. We started off with a dose of 100 milligrams per kilogram, which is a high dose, and that was an intentional decision in the design, because if we hadn't demonstrated the benefits we were expecting, we would have been accused for not having a sufficient dose, and no one really knew what the optimal dose should be at that time. However, with seizures being reported in cardiac surgery, which only happened after we started the trial, we reduced the dose to 50 milligrams per kilogram, and roughly 2,000 or so got either of those two doses. Our current practice at the Alfred Hospital in Melbourne is that we give a bolus of 12 milligrams per kilo and infusion 6 milligrams per kilo per hour. It's roughly about 40 milligrams per kilo for a 4 or 5 hour operation. That's our current practice. Certainly there's been lots of studies that demonstrated that the seizure risk is dose-related, and if you go to higher doses, the seizure risk increases, and we basically demonstrated that as well in the Atticus trial. And in fact, you didn't need such a high dose to get the blood-sparing effect you want, and I would agree with that. The bit that certainly most anaesthesiologists don't appreciate is that it is heavily dependent on renal clearance. And a lot of my colleagues simply don't recognise that fact and continue giving the same dose or a highish infusion dose without adjusting for kidney function. And that's very relevant in cardiac surgery, where about 30% of patients have renal impairment and about 5 or 10% have moderate or severe impairment. And you really need to drop the dose, at least the infusion rate, down quite a bit. Those with a history of seizures, which people often don't ask about, and of course at the moment there's a bit of a cloud over those who have got a familial thrombophilia. So coming back to the POISE-3 trial, absolutely no doubt confirmed efficacy. It does reduce bleeding and the need for blood transfusions. But safety, which they tested in a non-inferiority design, was not demonstrated. So coming back to POISE-3 for a moment. So this was a design. I'm big on trial design. I love trial design. A non-inferiority trial is that simply asking the question, is something as good as or as safe as, and you define a threshold of what that would be, and you build that into your design and your sample size calculation. And PJ Devereaux and the clever statisticians at McMaster did that, and they defined that as, I think it was a 12 or 12.5% increased risk. But in fact, it exceeded that boundary. So that's hence they could not demonstrate non-inferiority. Now that's just a polite way of saying they couldn't demonstrate safety. It's as simple as that. They argued that the incidence rate was very low, the difference was very small, and that was probably not significant, not clinically important. That's a value judgment, I guess. I would disagree with it. What worried me about it, because I do think if we're going to use it much more widely across a whole range of surgeries in an unselective way, in a non-precision medicine way, that in fact there were these little signals that just got me a little bit worried. Thrombotic signals, basically, non-hemorrhagic stroke, myocardial infarction, symptomatic pulmonary emboli, and also seizures. Now, none of these were statistically significant, despite being a very large trial. But I did note the seizures, 10 versus 3. Literally one more seizure in that group would have flipped it to this magic number, 0.05, p less than 0.05. I don't like doing that, but basically there was a threefold risk increase in seizures. This concerns me because I've had patients having orthopaedic surgery. You give a single 1 gram dose, and under full general anaesthesia with a very GABA-based general anaesthetic, having grand mal seizures under anaesthesia. Now, the implications of that for patients, for their social lives, for driving, for their work, for the healthcare system to fully investigate such an incident is quite dramatic. So widespread use of tranexamic acid for all types of major surgery, to me, requires much more confirmation around safety than it was demonstrated in that otherwise fantastic trial. And also they had this, this sort of composite outcome or a risk-benefit outcome, really weighing up the benefits of the bleeding versus the cardiac or cardiovascular complications. In fact, was not statistically significant at all. For them, they could not demonstrate what they called a net risk-benefit outcome. And at the same time, despite reducing blood transfusion, there was no reduction in infections, there was no reduction in hospital length of stay, there was no reduction in the number of days at home out to 30 days after surgery. So these are patient-centred outcomes. The patient themselves doesn't care too much about whether or not they get a blood transfusion. They care if it affects them in their daily lives or their recovery after surgery. So for me, there's some unanswered questions or some uncertainty that should reserve a guideline or a statement arguing that it should be routinely used. And also looking at their serious adverse events, which obviously occurred in a degree of patients, a little more so in the TXA group, and in particular cardiovascular disorders. So just little tiny red flags that continue the concern, despite me otherwise being very reassured in the coronary artery setting. Now, some of you may have seen this trial that came out a few weeks ago in JAMA. It's a nice randomised controlled trial, a bit over 1,200 patients based in Canada and the US. And it was a randomised trial of roughly 2 grams of tranexamic acid in patients having liver resection surgery. They found no reduction in transfusion. I'll be interested in your opinion on this too. I'm sure it surprised them. It certainly surprised me because I thought that should have happened. They did report an increased risk of complications in the TXA group, which seemed to be thrombotic related. Now, I would label this now as a moderate-sized trial, by no means as powerful or as emphatic or definitive as POISE 3. But it raises questions. Now, I knew Dominic was going to be introducing me today, so I had to have a couple of his slides here. I just want to change tack now and actually look at where else might tranexamic acid potentially have a role in the perioperative and perhaps trauma settings. And Dominic, in working with Rob Metcalf's lab, have done a lot of work looking at immune function and pro-inflammatory states. There's clearly a lot of data from many groups showing that, in fact, plasmin itself seems to be both pro-inflammatory and immune suppressive. And equally, studies that we did at the Alfred Hospital Melbourne, led by Dominic, that in fact, if you give tranexamic acid, you can block or suppress at least some of those effects. So there's at least some basic science suggesting that there's some other potential benefits in the perioperative setting. And as I said earlier, I am very worried about infections after surgery because they're the commonest serious complication after all types of surgery. So we were doing the Atticus trial at that point in time. Rob was working in his lab. I'd never met him before. He came and approached me during a talk I was giving and asked us, are you measuring infection in your trial? And of course we weren't. Our whole interest was around bleeding, blood transfusion and cardiovascular events. So we, from that time, actually built in prospectively a nested sub-study of all the patients who are enrolled at the Alfred Hospital. So 600 patients were enrolled at our hospital into that trial, and we got detailed, in a blinded fashion, detailed infection data of those patients. And we used the CDC criteria for surgical site and other infections. And what we found overall that there seemed to be at least a signal or a trend suggesting there was a reduction, particularly in surgical site infections. So I would label this as hypothesis generating. It's effectively a post hoc, semi-unplanned study, but seemed to support the hypothesis that there could be these additional benefits. And this was independent of blood transfusion, because even when we adjusted for it statistically or took out the patients who got a blood transfusion, the effect sizes were very similar. Now, another thing that Rob, because we have great conversations, he told me about this idea that what happened with diabetics? Did you have diabetics in the Atticus trial? It's cardiac surgery. 30% of all patients having cardiac surgery are diabetic. And he said, did you realise that plasmin is actually glycated in those who've got poorly controlled diabetes, the HbA1c, and therefore they've got less plasmin activity, and would that therefore affect your result? So we went back and looked at our data, and of course we had collected whether or not they had diabetes in our trial. And we went back and looked at the non-diabetic patients only. In other words, the ones where they would have higher levels or seemingly higher levels of plasmin activity, and the signal seemed a little bit stronger. Now, this is really fascinating for me as effectively a perioperative physician, because we've known for 50 plus years that diabetic patients need to have or should have good diabetes control before they have their surgery because of infection risk and other potential complications. So it's good practice for all doctors, I guess, in a hospital setting, is to find out whether or not the patient is diabetic, and ideally find out if their diabetes is well controlled, and if it's not, for elective surgery, we would defer surgery until that's the case. But we've now got another reason for why diabetes should be better controlled, but it's just a hypothesis. So we then went back and looked at our actual Atticus bleeding data, hypothesising that in diabetics their plasmin activity would not be so high, and therefore the TXA effect would not be so strong. So this is looking at the diabetics and the non-diabetics side by side, and if you look at it at least as a trend, there seems to be a stronger effect in non-diabetics. So again, the data is supporting the hypothesis, but I still think it needs further study and replication, but a very interesting finding. Now, all of that story was published by Dominic and us back in Blood Advances a couple of years ago. You can see all that information. Now, the other bit I want to just cover briefly is this concept of a potential effect on infection. So most of you will know that streptokinase was the first fibrinolytic drug used for obviously myocardial infarction and then other conditions. It, of course, comes from a bacteria. It's never dawned on me when I was a medical student that streptokinase comes from Streptococcus. And I think this is the first publication demonstrating that fibrinolytic activity from streptococci way back in 1933. So in terms of future possibilities, I'm actually also interested in whether or not tranexamic acid at whatever dose could also reduce infection risk after surgery. And importantly, is diabetes an effect modifier? In other words, does that of itself reduce or modify the effect that might otherwise be occurring, both in terms of bleeding complications, but also even in infection? So we set up what we've called the TRIGS trial, where randomising 3,300 patients having gastrointestinal surgery. This is a type of surgery that to date tranexamic acid is not used in or hasn't been in the vast majority of patients. There's a website there you can get more information. And our primary interest in this trial is the focus around infection. And unlike all the other trials that have been done, POISE-3, Women's Study and others, we've honed in to actually collect detailed infection data so that we've actually looked at that more closely. Because you know infections and DVT and so on are way more common than are being reported in those trials because they are very much secondary endpoints. Of course, we'll look at red cell transfusion and other effects. And we're also collecting blood and looking at HbA1c levels to see the extent of diabetes control in that diabetic group, which makes up about 25% of all the patients. And of course, Rob, with Tammy Lamb and others, are getting lots of blood specimens for their lab. Now, the great news about it is that although we had a setback I won't bore you with at first, we're well and truly on track to finish this trial, and we'll have full results of the TRIGS trial certainly at this time next year. We're expecting to reach our enrolment target in around about April, May, and then it's just a matter of course, cleaning and locking the database and doing the analysis. So I'm very interested in that one. And lastly, just for the last couple of minutes, I want to now move to a really terrible infection known as necrotizing fasciitis, or a necrotizing soft tissue infection, NSTI. Sorry for the figures, the images. They're probably worse than David Vose the other night. But it's one of the worst conditions we see at our hospital. We've got a hyperbaric chamber. Patients are brought there with high-dose antibiotics. They've got septic shock. They need major tissue debridements to control these spreading infections that are mostly due to group A streptococci. So there was a nice review article about this condition published in the Journal a few years ago. I won't go through the details of it, other than the bacterial infection can start off with not much more than a pimple or a cut, or even without any skin injury. And then the bacteria spread through the initially superficial, then deep layers of the tissues, and it's a spreading infection that literally can double overnight. And of course, with that comes septic shock, and it needs very extensive surgery and other treatments to try and salvage limbs and or lives. And the thing about necrotizing fasciitis is, as I said, it can come from all sorts of bacteria, but most are streptococci, and therefore they're secreting streptokinase in part to break down tissue barriers that the host response is trying to wall off, and it's actually the proteases, particularly streptokinase, is what's spreading the infection. So I thought if streptokinase is an integral part of that mechanism of spreading infection, seems to me that tranexamic should be able to prevent that from occurring. So this is just an idea or a hypothesis. We're doing a feasibility trial right now. These are very sick patients. We're looking at the feasibility of getting consent in a really critical care situation, where they're often rushed to theatre within hours. We want to see whether or not we can demonstrate that we can do what I would hope be a more definitive trial in the future. So we're testing feasibility, but equally we're testing efficacy to see if we can get signals of reduction in that spreading infection over that time. And this trial will also be finished next year. So I also want to acknowledge Dr. Utako Okamoto. I think tranexamic acid, for me, who's not a haematologist or a blood expert, but certainly works in the surgical setting, I think tranexamic acid, the drug itself, how we've learnt so much about it in literally the last 10 years, is phenomenal. Whether or not it has these effects outside of its blood-sparing effect, I think remains both an open question for further discovery. We're also doing some work around post-operative delirium. There's some biological mechanisms that would suggest that plasmin plays a role in some of that. But most importantly, of course, me as an everyday doctor, at least 2 days a week, what is the risk-benefit in non-cardiac surgery? What patients should we be using it? We are using it in joint replacement surgery, but what about all these other types of surgery? What patients may or may not be at higher seizure risk? What dose should we be using? When should we stop the dose? And so on and so forth. Lots more work to do. Thanks very much.